Okay, folks, come and grab a seat. Help yourself to some food. Sorry to our friends on Zoom, you missed this part of it. But yeah, help yourself to some food if you would like to grab some extra supplies throughout the presentations. Feel free to do so. But hey, lovely to have you here, and I am actually very excited about this. Good to see you, bro. I've been looking forward to this presentation. I would like to first of all say welcome on behalf of the. I'm going to be careful how I phrase this. The centre that specialises in health, nursing, and lifestyle medicine research. Right, we might have a name change coming very shortly, and that was just a bit of a heads up on what where we might be moving towards. But so I'd like to welcome you here. My name's Darren. I think I know most of you, but I am excited because this is just a stellar story that you're about to hear about and what's about to be showcased. I just asked Brett a moment ago. I said, "What year?" I was trying to do this morning. I was thinking, "What year was it that Brett arrived here?" And he said it was the middle of July 2013. So what it wasn't long before that was Tony Williams who was chatting with me, and he said, "Hey, we've found a gun researcher. This guy is early career, but he's going places." And I went, "Oh, really?" And I thought, "I wonder how you decide how do you figure that out?" But anyway, I thought, yeah. So let's see. So then this new young fellow, young, do you like that? This new young fellow arrived on the block, Brett, and I think that well, I know that Tony Williams was understating it. It's been remarkable to watch his career progression, and it happened real quick. But flash forward to today, he did do one stint with us, and then he got poached, and he went, no, 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 it's better back there. And so he's back with us now. But it's been incredible to watch your research career. Actually, to be honest, I've never seen anything like it, and it's been remarkable. So to sort of flash forward today, and I'm not going to have time to go through all the accolades, but an Order of Australia medal for his contribution to nursing, research, health, infection prevention control. Commonwealth Minister Award for Excellence in Health Research. Inducted into the International Nursing Researcher Hall of Fame. Multiple publications in Lancet. Most of us, if you get one of them, you just tap out. Like that's, I'm done. Hey, everyone. And you get a little badge that you wear. You say, I published in Lancet. Well, he has several of those. And I think it's over $20 million in grant funding now, isn't it, today? It's incredible. It honestly is incredible. And what I think I greatly admire all of that. But what I really do appreciate about Brett is just the spirit with which he does it. And I think that it just captures the essence of why Avondale exists, and that is to do research for good that has measurable outcomes, that makes a difference in the world and helps people. And so I just want to say in front of everyone once again, I've said this to you before, Brett, but I hold you in the greatest admiration, brother. And yeah, thank you. Give him a round of applause. He deserves that. But Avondale's really so fortunate to have you here, and we love what you do. And yeah, you're just phenomenal. And you've got a great team around you as well. And we're going to hear from all of them today. So I'm just going to hand this over to Brett. He's going to be talking about some of the work that's been done and some of these colleagues and students. But put your hands together once again for Professor Brett Mitchell.
Thanks. Well, that was not the introduction I was expecting. Thanks, Darren. That was very heartfelt, and thank you. I really appreciate it. But yeah, you're right about coming back to Avondale, because it is a place that genuinely holds true to its ethos, and there's not many organisations plenty of organisations have visions and missions and ethos, and not many hold true to those. And doing things for the betterment of others is exactly why I went into research. And everyone you're going to hear today is the same. And today you're going to hear from a whole range of different speakers, all with a theme about infection prevention and control. So that's one of the themes within the Lifestyle Health Nursing Research Centre that's way too long. So we're going to hear from all of them today, and it's a privilege to actually work with these guys, because you learn so much off all of them as well. So it's a real team effort. So I'm going to start by and welcome to those online as well. And this is the run through of what we're going to talk about. They're going to be very short, sharp, like 3 or 4 minute talks each. So I'm not going to hold this up too long. And we're going to hear from a range of different things. Now, I'll just put on this slide, which you probably won't be able to read, but this is a very small selection, number of projects that sort of fit in my portfolio at the moment. And these are the larger ones. I could probably go over 2 or 3 pages of different things. A lot of these are big trials involving multiple countries and thousands of people, and majority are funded. So these are some of the things you're going to hear about in green today. Just a couple of those trials or elements of those trials. So I'm going to start by talking about pneumonia. And pneumonia, we've all had chest infections. Pneumonia is simply that. And what I'm interested in, and we're going to hear about a little bit to start with today, is about pneumonia acquired in hospital. And it's very, very common infection. And you can see from this little video here, a little bit of what's called aspiration. You'll see a little bit of fluid starting to seep right about now. And just a little bit of micro aspiration. So we do that regularly. And as you get older, that micro aspiration can become more of the part of aging. When you're in hospital, you have drugs and medication that affects swallowing. You might have conditions that affect swallowing. You're sitting down, so you're not moving around like you have before. And Darren and I actually spoke years ago about getting people up and moving in hospitals. But there's lots of reasons why people have this problem. And so when you have bacteria that get into the mouth and you go to hospital, it can cause, when you swallow and have that microaspiration, that bacteria that aren't normally in your mouth can go down into your lungs and cause infection and cause pneumonia. Now, this type of pneumonia in hospital is really common. There's about 30,000 cases per year in Australia. Every year of people who get pneumonia in hospital. If you get it, you're likely to stay in hospital a lot longer, like a week to 2 weeks longer. You're 8 times more likely to go to intensive care. And your mortality is around 10 to 30% associated with this infection. So it is absolutely huge. It's a big impact for patients. It's a big impact for health services. And so there are ways to try and prevent this pneumonia from happening. Improving oral care is one of them. I'll come back to that. Getting people up and moving and trying to identify swallowing difficulties. But this is where the humble toothbrush comes into play. And so the first sort of study I'm going to talk about today is about brushing your teeth and why that is important. And the study that we it's still underway that you're going to hear about is called the HAPPEN study. There were 3 phases to this study. We wanted to find out why people in hospital weren't getting their mouth cleaned. And that's both from a clinical nursing perspective, but also from a patient perspective. We wanted to understand what were the barriers to doing it, what was the level's understanding. And so we did focus groups and we did surveys across Australia, and we had consumers. I've got an advisory group of about 9 or 10 consumers. We brought in partners like New South Wales government and tried to identify what these barriers were. And then we did a trial, a randomized controlled trial. I'm going to very quickly tell you about that today. And we wanted to test out this intervention of improving oral care in hospital and see whether it reduced pneumonia. And then we're going to move to another phase of the trial, which is about all the stuff we learned and resources, making that available for people to use. So this is the trial itself, the randomized controlled trial in a nutshell. Actually, no, George, I'm just going to grab this back. So what we did is what we're interested in is trying to reduce this pneumonia in hospital down. So what we did was this cluster randomized controlled trial in 3 hospitals: the Sydney Adventist Hospital, Gosford Hospital, and the Royal Melbourne Hospital. And there were different wards within those hospitals participating. Everyone's just business as usual to start with in the control phase. At random points in time, people get into the intervention. The intervention consisted of patients receiving a pack, not too dissimilar to this. And in the pack was very, very sophisticated things: a toothbrush and a toothpaste, right? Because people go to hospital, they don't think about packing a toothbrush. It's sort of probably the last thing you think about. And patients don't know that brushing their teeth in hospital might actually reduce the risk of pneumonia for them. So they got given a toothbrush, and on the toothbrush, actually, it opens up so it's a bit thicker, so patients with dexterity can hold it properly. And there's some prompts on there that the consumers came up with, like brushing prevents pneumonia, brush away pneumonia. Some toothpaste, and then on the bag itself was a QR code which had information for patients to find out about why brushing your teeth is important, how to do it, a whole range of things. At the same time, we did education with nurses on the ward about why oral care, as it's referred to in nursing, is important, and some resources to help them, just-in-time resources to help them dealing with more difficult situations around oral care. So what have we found? Well, this study involves about 8,500 participants, so it's the largest study of its kind ever done. And what we found is really big reductions in pneumonia associated with this intervention. So at an individual risk level, brushing your teeth in hospital between once and twice a day will reduce your risk of pneumonia by 60%. 60%, absolutely huge reductions. If you were to implement this at a hospital level, because we sort of looked at it both ways, it's the same result, very similar result, but 50-something%. So massive reductions in this risk of acquiring an infection that's got a reasonable chance of killing you, or making you stay in hospital longer. And so the implications for this huge. The humble toothbrush has got a lot to say for in this study. And we got oral care improved from, on average, 15% of the time people were brushing their teeth once a day in hospital, which is pretty low.
Okay, it looks like we're back in business. So thank you. Sorry for the glitch for those online. My name's Sonia Dawson. I work with Brett. I've been at the Avondale in the School of Nursing for 18 years. And I was privileged to be a part of this study from a qualitative point of view. So the randomized controlled trial is quantitative, and what we decided, or what happened was I did some interviews with nurses and patients along with the team. It's not going to progress. Seized up. Anyway,
Let's go out and go back. There we go.
Okay. So Brett's just told us about how important it is to clean our teeth. So what we wanted to do was to actually see, while the intervention was happening in these various hospitals, the 3 hospitals that this trial was happening in, what the experience of the nurses was and the experience of the patients was. So what we wanted to do is to ask questions about how the trial was running, how they found the intervention. Were there things that stopped them from doing that? Were there things that enabled it? And so what we did is interview 26 nurses. So there were 3 cohorts of patients that we had in this study. We had research nurses that were employed as part of the trial to actually facilitate the research in the hospitals, enroll the patients, and follow through, and to make sure that they were getting connected with the QR code and various other things. We had some ward nurses as part of this. So 18 ward nurses were interviewed, 8 research nurses were interviewed, and 3 patients were interviewed. And we only had 3 patients because they were ones that had actually developed the infection while they were in hospital. And obviously with various vulnerabilities and perhaps cognitive issues, we didn't get as many patients as we actually hoped. But the time frame was just a couple of months in last year. And so what we did is we interviewed people over the phone. We audio recorded them after they'd had been given consent, and we transcribed all of what they were asked. We had some semi-structured interviews, and they were asked things like, how was your experience of the trial? Were there issues with being able to follow through with it? So for the nurses particularly, what were the barriers to what they did? And then when we had all of that data, we actually analysed it in a particular way that nurses do often, called thematic analysis, and we came up with themes. And there's 4 themes that we came out with for this data. And I'm there's a lot more that I can't say it all, but these are the 4 themes. Very briefly, the first theme involved showed that there was a real mixed reaction to nurses, first of all in their understanding, but also in their capacity to follow through with it. So nurses are very cleaning someone's teeth or helping someone to getting their teeth cleaned is very fundamental to nursing care. But what we found when we did some interviews is that some people were very connected with that and wanted to do that. And we didn't ask them which uni they went to do their training, but obviously some people were very connected with holistic care, and that was very much a part of what they would do for their patients. And others said, I didn't go to uni to learn how to clean someone's teeth. And so there were polar opposite responses for that. And one of the nurses was heard to say, well, you know, in terms of wanting to do this intervention, I haven't got time to do that. You know, you just give me more work to do. And so that was the first theme. The patients, by contrast, were very appreciative, and they appreciated the pack that they were given. The second theme covered just inconsistencies in understanding. So nurses, some nurses, again, depending on where they had learned how to be a nurse and where they had worked their experience, some nurses were actually very connected with the fact that cleaning someone's teeth would actually prevent pneumonia or reduce the risk of pneumonia. Others didn't have any connection at all. So there was a gap in the knowledge, both in training and then inconsistencies in actually nursing practice themselves. The third one, I'm going to rush over this because I know I've got such a short time, but there was competing demands and resistance, so barriers for that in practice. One nurse described oral care being squeezed out amid showers, medications, and managing confused or aggressive patients. And oral care was seen as extra, and rather than the core nursing work. And so that was, you know, quite an issue. There was system level, so there was patient level barriers where you know, they particularly came into hospital and, you know, they might have been having, you know, big surgery, and they're like, cleaning my teeth's the last thing on the list I want to do. I'm too sick to worry about cleaning my teeth. And so they didn't want to clean their teeth while they're in hospital. Others said that they were about to clean their teeth, and then the blood taking lady came in and interrupted them. So there were system things that stopped them cleaning their teeth. And then obviously there were some issues with perhaps aggression or dementia or cognitive decline where you know, they were unable to do that. The last theme was about relational and functional support. So we found that nurses told us that if they actually developed a relationship with the patient or with the family, it made a real difference to them being able to follow through. So rather than just walk in to a room and say, Mr. Jones, you have to clean your teeth now, they would actually go in daily, remind them about the project or the study that was going on. The patients had consented to be in that. And then after they had developed this relationship, they were much more friendly, and some of the patients would wave to the nurses in the corridor and say, I cleaned my teeth today. So that was one of the things. So what does this mean? What worked what worked, and what limited the things, and what can we actually do to change the outcome? What we found was in alignment with what existing literature already says. So there was nothing really new about understanding the barriers to what happened when the trial was taking place. But there is an opportunity to actually increase or to introduce several practical improvements in hospital routines. And so there were lots of things within the trial, and we haven't had time to explain them yet, but there was a QR code on the pack. There was posters in patients' bathrooms. There was queues with perhaps the research nurses. Some of the hospitals, they wore T-shirts that had teeth on them. And so there was a reminder every day about cleaning your teeth. And so if we consider cleaning someone's teeth as a core nursing activity, we could embed it into practices much more than what it is. There could be flags in the medical electronic records, just as we have flags to give medication at certain times. There could be a flag to say, make sure that someone's cleaned their teeth twice a day. There could be more posters and things around making the link between the cleaning teeth and pneumonia. We could also embed this knowledge into nursing curricula much more, and also have competencies in clinical placements, for example. So the implications really is that at pre-registration and post-registration, we should be using evidence-based resources like this to be teaching our nurses, and also then following through with them as they're working in the wards. Ongoing training and support for nurses that have been registered a while and that are out in the clinical area to help them deliver the oral care safely, and helping people understand the link, giving patients more health literacy around this topic as well. Because most people would say if they knew that cleaning their teeth once or twice would reduce their risk of pneumonia, they would like to do it. And that's what the patients, even though we only had 3, that's what they said, is that of course we'd like to clean our teeth if that's something that would have prevented us from having. And obviously there's other things as well. So finally, I suppose what we'd really like to do is to keep going with this, and doing perhaps a wider study as well about how we can actually, so a sort of intervention about how we can introduce this in nursing practice across the tertiary sector in terms of education, and then also out in clinical practice. So thank you for listening. Or I've gone more than my 4 minutes, but I'll pass it over.
Thank you. Thank you so much, Sonia. And I'm going to invite Marnez to come up and have a chat to us about a different study, which is about trying to prevent urinary tract infections in hospitals. And this is a study that, I'm just setting the scene here for you, Marnez. It's one of the studies that we tried to do with a randomized controlled trial, and we tried to do it for a number of years, and it never happened. It was one of a failed study, and you never really hear about failed studies. It cost a lot of money and a lot of resources, and we didn't actually get to do it. But what we did get to do was pivot and do something else in a hospital, and also do some really important work around some qualitative work that Marnez is going to show you now. So thanks, Marnez.
Yeah. Okay. Good afternoon. I'm Manas Fanayan, Senior Lecturer in Nursing in Sydney campus. So today I'm going to talk about our qualitative study that we did exploring the perspective of individuals who undertake clean intermittent self-catheterization, and we wanted to know their experience with urinary tract infection as well. So there is this paper is published in Infection and Disease and Health, and also this QR code is linked directly to the open access article. So the clean intermittent self-catheterization, or we call it CISC, is an effective and recommended way to treat urinary retention. So also the person who they perform this, it becomes part of their everyday life. So when recurrent urinary infection or UTI happens, then it becomes burden, which can practically extend well beyond physical symptoms. And then we can see that the problem that happens with this and their experience that they had. So we wanted to know, how do they feel? How does it affect them that they have to self-catheterize a few times a day and try to prevent UTI as well? So we conducted semi-structured interview. We had 14 people that they were from community settings across Australia. There were 9 women and 5 men. The median age was 60 years old, and also the median catheterization history was 4.2 years. So rather than focusing simply on infection and also the rate of infection, clinical outcomes, we wanted to know what was their experience. How did they feel? What are some of the barriers for them to everyday life? So we asked them about the experience of catheterization, UTI treatment, healthcare access. We look at the facilities that they are using. And also we wanted to see that how did it affect them in their social life. So we interview analyzed by Brown and Clark's 6-step reflexive thematic approach. So we have 4 interconnected themes that emerged from this study. Participants described not only physical symptoms, but also psychological exhaustion. Catheterization influenced their social life, and it made it more difficult by inadequate public access and facilities, especially the toilets. They also experienced barriers to timely treatment and management of the UTI, and they were concerned about the self-medications and also antimicrobial resistance. So importantly, continent nurses, they were highly valued, and with continuity of care and funding, they remain a source of concern. So our findings suggest that CISC care needs to be extended beyond bladder management and infection control. We need to treat the individual based on the person-centered care. And we have to recognize the cumulative burden, the timely access to the UTI assessments and management and treatment, and a strong continuity with the continence nursing agencies. These are the important things that we found. So, of course, psychological, we can look at the social and practical impact also needs to be checked. And the key message from this study is that successful CISC care is not only about the bladder management and infection prevention, it is about enabling people to live well. Thank you.
Thank you, Mana. You can see the theme that's sort of coming out about people living well and in the sort of wider impacts that someone says. I can't remember the stat, Mana, but was it something like 40,000 people a year undertake self-catheterization? More than that, yeah. And so people who might have had a cancer, for example, or they might have a motor vehicle accident or related things that don't enable them to be able to have normal bladder function and require this catheterization. So huge impact for lots of people across the world. We could tell heaps of stories about that, but maybe for another day. Now, changing tack completely differently, and this is trying to showcase a whole breadth of different things. George is going to talk to us about a bibliometric review and some of the methodology behind that in cases of interest. Thanks, Georgia.
Awesome. So for those of you who don't know me, my name is Georgia and I'm a research assistant here at Avondale University. And today I'll be talking about the use of bibliometric reviews in infection prevention and control, or IPC. And I'll be sharing 2 insights from 2 recent reviews that Brett had led that I was lucky enough to be a co-author on. Before discussing the reviews, I would like to briefly explain what bibliometrics are. So bibliometrics comes from 2 Greek words. The first, biblion, meaning book, paper, or written work, and the second, metrics, meaning measurement. So put simply, bibliometrics is the measurement of literature. Instead of analyzing one paper at a time, bibliometrics allows us to understand the bigger picture. So who is publishing research? Where is this research being published? Who's collaborating? Which topics are growing? And where do the evidence gaps exist? So this is a very basic outline of how to undertake a bibliometric review. So first you start with your defined topic and exclusion criteria. We then use a systematic screening tool called Providence to screen articles against our eligibility criteria. Included articles are then put into a bibliometric software, which allows us to map publication trends, collaboration network, authorship patterns, and research impact over time. We also used AI assistance in the form of Claude to map study design, study settings, and research themes. So I'm going to briefly discuss the results from 2 bibliometric reviews. The first focused on Australian research in infection prevention and control over the last 2 decades, and the second was on global randomized controlled trials. You can access either paper here via the QR code, or the QR codes will also be available throughout the rest of the slides. So I'm going to start with the Australian IPC research overview. So Australia is internationally recognised as a leader in IPC research. However, up until this review, there had been no broader assessment of the wider Australian IPC landscape. So we aim to identify patterns and trends in Australian IPC research over the last 2 decades. We screened over 4,000 articles with 841 included in the final analysis. So we were able to determine that research output had grown substantially over time. This was particularly evident after 2013. We're also able to determine that Australian researchers had really strong international collaboration. In terms of study settings, we're able to determine that majority of studies were undertaken at a single site rather than over multiple centres. And then in terms of study design, we're able to determine that majority were observational in nature rather than really high quality randomized controlled trials. So the second review actually focused on randomized controlled trials, and randomized controlled trials are known as the gold standard as far as evaluating healthcare interventions. But randomized controlled trials are also incredibly difficult to undertake, and a lot of IPC guidelines do rely on really low quality evidence. So we aim to identify trends and patterns in global IPC RCTs over the last 2 decades. We screened over 2,000 records and 239 worldwide RCTs were included in our final analysis. So I think one of the most important findings was the rapid growth in infection prevention and control RCTs, and this is particularly evident in the last 2 years, where over a quarter of all RCTs were published. When we were looking at what these trials were on, majority focused on medical devices. So these are things like your urinary catheters. When we were looking at citation and collaboration impact, we're able to determine that majority of studies were undertaken in a relatively small amount of countries, particularly the USA, Australia, and the United Kingdom. We're able to determine who the highest contributing authors were in the field, as well as the collaboration networks in the field. And then at an institutional level, we're able to determine that Australian institutions were leading the charge. So together, these studies highlight the strengths of bibliometric reviews in IPC. They help us to understand where research gaps exist, where the strengths exist, who's collaborating, and where investment in the future will have the greatest impact. Overall, the findings show that infection prevention and control research continues to grow, while it also shows and highlights opportunities to strengthen the evidence base in order to benefit patient outcomes. Thank you.
Well done. Thanks so much, Georgia. And we wanted to share that one because it's just a different type of methodology and could be applied to a whole range of different disciplines. And I got introduced to this through colleagues who actually were doing it in a podiatry setting. So it was a really interesting exercise. And it's amazing how much metadata is now captured in journal articles you can analyze. So, all right, now changing tack to Hannah. Now, Hannah is here virtually via video. And Hannah is one of my PhD students and is going to talk to us about her work on contemporary aseptic technique. And hopefully we will get this video to work.
Good afternoon, everyone. My name is Hannah Kent, and I have the pleasure of presenting my doctoral research today. I would also just like to acknowledge my incredible supervisors and co-authors, Dr. Sonia Dawson, Associate Professor Joanne Lewis, and Professor Brett Mitchell. So my research focuses on the contemporary clarification of aseptic technique in clinical nursing practice. As some of you may not have a healthcare background, I'll just briefly explain what aseptic technique is and why it is so important. Aseptic technique is essentially the practice clinicians use to prevent harmful germs from being transferred to a patient during routine healthcare procedures. The goal is to keep important equipment, surfaces, medical devices, and vulnerable parts of the patient, such as an open wound, as free from contamination as possible, reducing the risk of infection. Aseptic technique is therefore a foundational element of infection prevention and plays an important role in reducing healthcare-associated infections. So what was the problem or the gap that I found? So in essence, despite aseptic technique being a fundamental part of nursing practice and important to patient safety, there is a lack of consensus around its underlying principles, and there is no consistent or standardized approach. The terminology and principles of aseptic technique also remain inconsistently defined within the literature. Research from the UK demonstrates considerable variation in nurses' understanding and application of aseptic technique, as well as variation across national and international guidelines surrounding aseptic technique. Therefore, the aim of this program of research was to establish empirical foundation for a contemporary principle-based approach to aseptic technique in clinical nursing practice. So this particular area has limited empirical evidence, and particularly within the Australian and New Zealand context. So because of this, multiple studies were needed to address the overall aim of this research. A multi-phase sequential research design was used, with a series of studies conducted so that each phase helped inform the next and then contributed to the development of a broader body of evidence. So phase 1 explored the international literature surrounding aseptic technique. Phase 2 explored how nurses understand and apply aseptic technique within the Australian and New Zealand context. And then finally, phase 3 aimed to establish expert consensus on the principles of aseptic technique. So the first phase and publication was a scoping review of the international literature. After screening 2,812 studies, the 31 included studies identified notable variation in the terminology and definitions surrounding aseptic technique. The second phase and publication was a cross-sectional study involving 328 Australian and New Zealand nurses. And this actually revealed considerable variation in how the principles of aseptic technique were understood and applied. And the third phase was a real-time Delphi study involving a panel of 49 Australian experts, ranging from infection prevention nurse specialists to nurse educators, etc. And they were able to reach a consensus on the principles underpinning aseptic technique. And a paper is currently under review in the Journal of Advanced Nursing. So the culmination of this program of research was the development and the proposal of the Principles of Aseptic Practice, or known as the PAPs. So these have the potential to support greater consistency across clinical practice, education and governance, and ultimately contribute to hopefully improved infection prevention and patient safety. There is, however, more work to be done in this space. While these principles have been empirically derived through expert consensus from this research, their impact on education and clinical practice and infection prevention outcomes is not yet known. So watch this space. If you have any questions, please feel free to email me, or maybe one of my supervisors might be able to assist. And I'd just like to thank you very much for your time.
And I know obviously Hannah can't hear us, but
Good afternoon, everyone.
we don't need to hear from Hannah again. She just submitted her PhD for examination as well. So it's a massive milestone just in the last couple of weeks. So well done to her, and there's plenty of exciting things to come from that piece of work as well. Now, talking about exciting things, another one of my PhD students, Michelle, has been doing some work around pneumonia prevention. And so, Michelle, I'm hoping that now you can share your screen, and I'll stay up here until we can see your screen is being shared and we can let you take over. Michelle's joining us from Dubai, I think, at the moment. Is that right, Michelle? Now, can't hear you. Do you want to, oh yeah, there we go. And you're unmuted. Cool, we've got your screen up, Michelle.
There we go. Can you see?
Yeah.
Perfect. Thank you, everyone. My name is Michelle Chalker. I'm one of the nursing lecturers here at Avondale and a PhD candidate. I want to acknowledge Professor Brett Mitchell, Dr. Kate Brown, and Professor Philip Russo, who's from Monash University, as my supervisors. Okay, I'm just going to give a brief overview of what I've achieved, what I'm working on in this research. So my research is on the impact of non-ventilator healthcare-associated pneumonia, or NVHAP, which I'll call it from now on, in Australian hospitals. So initially, I undertook a systematic review on the impact of NVHAP on mortality and additional length of stay. This was the first time this systematic review was undertaken, and that was published in January in the Journal of Hospital Infection. And I'm going to be presenting that findings from that systematic review in a conference in November in a poster presentation. Then I undertook a retrospective multi-site cohort study on the Central Coast with 7,641 participants, and I've completed the data collection and data analysis of that. Oops, well, let me just, there we go. Okay, I'm currently working on publication 2, which is again, multi-center retrospective cohort study on the incidence and mortality of NVHAP in 2 Australian hospitals. I have a targeted Q1 journal in mind, and I am just about finished writing that. I'm presenting the findings from this study in a lightning talk in that same conference in November. The research gaps address, this was a first multi-center study in Australia to assess the incidence and inpatient mortality. This is background information to know what is the burden of NVHAP within Australia. And this background knowledge of incidence and mortality will help assess the effectiveness of prevention strategies, such as the CLEAN study and other studies that may come ahead. Now, there's a potential additional publication from this publication of a case control study, but no decision has been made on that as of yet. All right, I have another publication which I'm starting writing. This is all from that same cohort, retrospective cohort study. This looks at the attributable hospital length of stay associated with NVHAP. It's background, again, background knowledge about how many additional days of stay is attributed to NVHAP. And there's lots of ramifications for why there's such a big issue with additional length of stay. What's interesting about this research is this is a new method of calculating length of stay due to a healthcare-associated infection. And from my systematic review, none of those 49 studies in that review have used this method to calculate this length of stay. So this is going to be a really interesting, more accurate identification of length of stay due to NVHAP. All right, I will be starting to write soon. My publication 4 or potentially 5, it's a comparison of non-ventilated healthcare-associated surveillance definition in identifying cases. So currently there is no gold standard surveillance definition. You can contact me if you want to hear more about that. And so what I've done in my cohort study is I'm going to be comparing different definitions to see whether these definitions have successfully identified that case. So the research gaps address is that it's more evidence to show that there needs to be a global consensus on a gold standard surveillance definition. Brett. And I'm hoping to get all of those submitted by the end of year to write up my thesis and to be submitted by this time next year, or hopefully even earlier. All right, that is me.
Thank you very much, Michelle. And you know, I don't. Michelle, I think, undersold herself a bit there because contributions that Michelle's work is making is huge. Just on the length of stay part, how much extra someone stays in hospital has a huge impact for a whole range of different things, like how much funding goes to hospitals, how many bed days are required by way of this infection in hospital, and therefore what if you were to invest in prevention strategies, what are you opening up? So if you think about the 40,000 cases each year in Australian hospitals, if they stay in hospital, I don't know, whatever Michelle finds, and this is make up a figure of 10 days, that's 300,000 more hospital bed days or extra hospital bed days used every year. So then you start to have an amount where you can quantify a prevention strategy against that. 10% reduction could mean basically no waits for elective surgeries because you've got bed days for people who have their hips and knees replaced. So the implications are really huge. So thank you, Michelle, for that. I think I'm just going to go through that. Okay, so that sort of wraps up. I'm going to go to the last slide. That wraps up the sort of talks from today. As I said, this was a bit of a snapshot of some of the things we're up to. I couldn't be prouder of the people who presented today, and the many also who didn't present today, who I work with and have worked with for a number of years, who've really contributed to these projects as well. I think Kate is online, Kate Brown being one of those, but certainly many others from many other institutions as well. And just to give you an example from the HAPPEN study alone, that involves something like 40 to 50 different researchers and nurses across different organizations. So really, this is about also capacity building in this space. Fortunately, we're all going to end up in hospital, either ourselves or a loved one we know. And what we're aiming to do collectively as a group and through these pieces of work is reduce the harm that can be caused in hospitals to you and your loved one. And hopefully that gets minimized in the future. So thanks, Darren, for the opportunity to showcase some of this work today. I really appreciate it.
Thank you to all the presenters today. Fantastic stuff, and it's just amazing to see a momentum going with so many people involved. So, yeah, I want to thank you once again, Brett, for all the work you're doing and the way that you've been able to pull in so many other people to all the projects. It's just fantastic, and Avondale's super proud of the work and the contributions being made. So, thank you everyone for joining us. There's some food left up the back there. Feel free to help yourself before you leave. But thank you. Till next time.